البانل كيف أخليها فوق؟ تغطي لها على السلايدز.
على صوب لازم. يبقى نبدأ.
يلا بسم الله.
يلا بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening all. Thank you for joining tonight's Zoom meeting, which is part of the 1Diabetes Association and lecture series. We are excited to have you all with us. I'm pleased to introduce our guest speaker tonight, Dr. Azza Shidani, who is Senior Consultant Pediatric Endocrinology and Head Unit of Pediatric Endocrine Senior at SQH and University Medical City. She will be talking tonight about Ramadan fasting in children with type 1 diabetes. As we are approaching Ramadan, كل عام وانتم بخير, all of you. We know that fasting during Ramadan can be challenging for the children with type 1 diabetes and their parents. So we're happy to have you, Dr. Azza. We know that you will share with us your insights and strategies to help the children with type 1 diabetes for fasting safely. We will have time for questions at the end of the talk. So please keep your questions in the Q&A section in the Zoom. So with no delay, Dr. Azza, the mic is yours.
Thank you, Dr. Ramoza. شكرا جزيلا. And I'd like to thank the 1Diabetes Association for giving this giving me this opportunity to present in this important topic at this time of the year while we are approaching Ramadan. إن شاء الله وكل عام وانتم بخير جميعا. So without any due delay, we'll start. I have no disclosures, and this is the outline of my presentation. So as you know, Ramadan is weighted every year by all Muslims around the world. Around 2 billion Muslims are witnessing and fasting Ramadan every year. And it's a time for spiritual reflection, and as it is a fundamental pillar of Islam, and it's a time for spiritual reflection and seeking forgiveness and strengthening one's faith. Individuals with medical conditions, though they are exempted from Ramadan as fasting Ramadan as it compromises their illnesses. Saying that, many, as we know, Allah subhanahu wa ta'ala in the Quran said, فَمَنْ شَهِدَ مِنْكُمُ الشَّهْرَ فَلْيَصُمْهُ وَمَنْ كَانَ مَرِيضًا أَوْ عَلَى سَفَرٍ فَعِدَّةٍ مِنْ أَيَّامٍ أُخَرَ. That's so whoever sight the month should fast, and whoever ill or in journey are exempted. And this exemption, as we said, it's there, but there is lots of misconceptions with the diabetic, people living with diabetes regarding this, and it's our role to guide them on this and identify these misconceptions and explain it to the patients. There is individuals exempted from fasting, they are children, so those with illnesses, travelers, and women with specific reasons, and anyone with reduced mental capacity. So it should be clear for our patient that they are exempted from fasting, and they have no haraj in not fasting Ramadan, and this should be clear for all of them. Why we are saying that? Because fasting in type 1 diabetes specifically have lots of risk and complication on these patients, mainly hypoglycemia, and that usually happens 3 to 4 hours before iftar or breaking fast. And we know that hypoglycemia have lots of serious and lethal implications for these children. They also prone to hyperglycemia and dehydration, and that can lead to DKA, which also a serious complication of type 1 diabetes. For these reasons, multiple authorities and consensuses through the years was considering type 1 diabetes as high risk, and they always recommend them not to fast. Saying that, do the patient follow this? Actually, in a study done by the Diabetes and Ramadan International Alliance in 2001, that showed that around 43% of type 1 diabetes patient and around 79 of type 2, they are at least fasting 15 days during Ramadan, at least 15 days during Ramadan. And in a survey done in the MENA region showed that the adolescent reporting a higher intention to fast than adult, approaching 76% versus 70% for adults. So even though we are advising them not to fast for many decades, people do fast. And especially the children and adolescents do fast. So colleagues from Kuwait, they went and explored why these kids want to fast. And the main three reasons found in this study that they feel the pride to fulfill the religious obligation. They are happy and sharing their experience with the community, and they are stigmatized, so they are avoiding that stigma of not fasting, of not fasting while all people are fasting, and feeling of normal like a normal like peers. So to fast or not to fast? This is the question that always raised and for us, and and most kids actually, they do come to the clinic and they are requesting to have guidance in fasting, and they want to fast. As I said, they do feel stigmatized in their schools when they go to schools that all their peers are fasting, they are not fasting. So what is now we are in a place that we need to do something, and reviewing the literature, recent literature, that it showed actually that Ramadan fasting among type 1 diabetes and adolescent by itself is not associated with short-term glycemic deterioration if it is guided, and if these patients were educated and stratified. There's another study also confirming the same thing. There's no significant deterioration of indicator of overall glycemia between pre and post Ramadan. So the evidence is accumulating that there is a situation where you can allow these children living with type 1 diabetes to fast. And here comes in when the Diabetes and Ramadan International Alliance, for the first time in 2021, they devote a full chapter for management of type 1 diabetes when fasting Ramadan. And actually, we take most of our recommendations from this guideline. So the key here is individualization. You individualize your patients and stratify them and give guidance to allow them to fast. So to start with, you need to start with a pre-fasting assessment. So there is diabetes care team need to do a full medical evaluation, risk stratification, and education for the children and their caregiver on glucose monitoring and insulin adjustment. So what is there in the risk stratification of these kids? So we need to go through what was the pre-Ramadan glucose control, the duration of type 1 diabetes, newly diagnosed diabetes. They are not supposed to, they should not be allowed to fast because they may enter a honeymoon period and their blood sugar may be, their insulin requirement and reduce, and then again they go into high requirement, and that may disturb their fast and it can be dangerous for them. Is there hypoglycemic risk? What is the history of hypoglycemia before Ramadan? Level of hypoglycemia awareness. Are they aware about their hypoglycemia? The level of diabetes-related education. Is the motivation for self-monitoring of blood glucose? And they have the ability to take appropriate decision-making when they get hypoglycemia? Do they have access to continuous glucose monitoring and advanced insulin delivery techniques? And lastly, do they have any other association with diabetes and other complication or association with diabetes? In summary, you need to do a full assessment of these kids before Ramadan and stratify them. The DAR, they developed this risk calculation and suggested risk score for people with diabetes. And if you go through this risk stratification, you can stratify your patient as is he low risk, moderate risk, or high risk. So mainly high risk means they have severe hypoglycemia, they are prone to decay, they have recent DKA or prone to DKA, they have poor glycemic control. Moderate, they are well controlled, type 1, with no recurrent recent complication. And usually rarely they are certified as low risk as they are on insulin, multiple daily injection insulin. So after certification, you give them your advice and guide them on and educate them. So we need to educate these kids on their blood glucose, the need for frequent blood glucose monitoring, fluid and dietary advice, physical activity and exercise advice, how to adjust their insulin during fasting, when to break the fast, and how to recognize hypoglycemia, and how to manage. And if we did this before Ramadan, like 3 to 4 months of Ramadan, and then we allow them for break the fast before Ramadan, that will be the most appropriate thing to do and to allow them to fast safely. Now, in terms of blood glucose monitoring, the recommendations say that children living with type 1 diabetes, they should test at least 6 times a day, pre-dawn, in the morning, midday, the afternoon, before iftar, and 2 hours after iftar, and anytime they are unwell, they have hypoglycemia or hyperglycemia symptom, or they are sick. Also, it's recommended for these kids to be on continuous glucose monitoring, because it gives a real-time trend, blood sugar levels and trends, and that will guide them on when to break the fast and how to manage their blood glucose fluctuation. And as I stressed before, they need to recognize and treat hypo and hyperglycemia guided by their blood sugar monitoring. In terms of insulin adjustment, so most of our kids are on basal bolus regimen, which is the standard of care for children with type 1 diabetes. And if the recommendations say if their blood sugar is controlled, their A1C is 7.5 and below, they should reduce their basal insulin by 20 to 30%, and then they should take it at iftar or at late evening or as pre-Ramadan time as usual. If they are uncontrolled, there is no adjustment. They should continue on the same dose they are using pre-Ramadan, and they adjust according to the blood sugar monitoring. For the meal insulin, the fast-acting insulin, if the child is carb counting, so they follow the same. They use their insulin to carb ratio and insulin sensitivity correction, and to continue. But if the patient is on fixed dose, they need to reduce it by 20 to 30% in sahur, but continue the same for iftar. So, few notes regarding the prandial insulin. For better response, they should take it at 20 minutes before iftar to account for hyperglycemia. And if they have hyperglycemia, they should correct according to their insulin sensitivity, but they should not correct less than every 3 hours to avoid stacking of insulin and that will prone them to hypoglycemia. By the end of the day, individualization is the key here, and they should all of this is a start, and then their insulin doses should be guided by their blood sugar monitoring. Conventional and twice daily regimen or pre-mixed insulin is not recommended actually for children living with type 1 diabetes, and study showed that this regimen brought them more to hypoglycemia with or without ketosis during Ramadan than those on basal bolus insulin. So it's not recommended to use this regimen. For children who are on continuous subcutaneous insulin infusion, which is insulin pumps, if their basal insulin should be reduced by 20 to 30% 4 to 5 hours before iftar to reduce the hypoglycemia risk at that time. And it should be increased by 10 to 30% after iftar to up to midnight to allow for to reduce the hyperglycemia risk. For the bolus insulin, they should use the same insulin to carb ratio and insulin sensitivity factor. These kids also, they should be given advice on nutrition and hydration, and their meals should be balanced with complex carbohydrate, proteins, and healthy fat to prevent rapid glucose fluctuation. Also, they should be advised to drink lots of water during breaking fast, and they should avoid large meal with excessive carbohydrate intake after breaking, especially with simple sugars to avoid hyperglycemia. These all kids who are going to fast Ramadan, it's recommended to see the dietitian prior to Ramadan fasting to guide them on this. In terms of physical activity, moderation is the key. So they should not do strenuous exercise. They should do moderate exercise, and preferably during fasting, during breaking fast, not during the fasting hours. And they should know that they should break the fast if their blood glucose is below 3.9, or if their blood glucose is between 3.9 and 5, they should recheck in 1 hour. And if it is going down, they should break the fast. And if they are hyperglycemic, also above 16.6, they should also break the fast. Or if they have any symptom of hypoglycemia or acute illness, so they should be told that they should break the fast anytime they have hypoglycemia, they are ill, even if there is only minutes before iftar, because this is dangerous for their health. In our clinic, we use this leaflet to guide the children with type 1 diabetes who are opting to fast, and we advise them to monitor 6 times and extra if there is any, as we said, symptoms. And we give them a starter guide for insulin regimen. As we said, individualization is the key. Some families, they have 3 meals in Ramadan. Some family, they have 2 meals only. So accordingly, you advise them about their pre-meal blood sugar, insulin. And it should be clear when to break the fast. And we also explain here that they are not mandated to fast according to the Islamic rules. Lastly, about the role of smart insulin pumps in fasting Ramadan, the automated insulin delivery devices. So automated insulin delivery devices are, they give automated basal rate adjustment based on CGM, and they have the predictive low glucose suspend, so the machine will suspend the insulin infusion if there is a trend for lows before the hypoglycemia, so it prevents hypoglycemia. As it's a dynamic insulin delivery system, which is hyper closed loop. it reduced hypoglycemia risk by 30 to 50%, and it improved the time in range by 10 to 20%. So it's a very good device in helping children living with type 1 diabetes to manage during fasting. And it also lowered the caregiver burden through automation and alerts. This is a study done actually in adults, but it's with type 1 diabetes, but it also shows that those compared to other regimen on insulin, those on smart pumps, they have less, they have higher rates of fasting and best glycemic control during Ramadan. So they break their fast only 2 days in the full month compared to others. And they have their time in range is around 73%, and they have less hypoglycemic events. So also in a recent recommendation, systematic review and recommendation by the group of also same of DAR, they said that the aid system, they are associated better glycemic control and higher number of fasting days compared to other treatment modality, ensuring low rates of hypoglycemia and diabetic ketoacidosis. So practical guide on using these devices to set a temporary glucose target around 6 to 8, to trust the CGM pump integration. But if there is any concern, they should use the blood sugar check, because it's very important to make sure that there is no problem with this, and to avoid a manual override unless their blood sugar is critically high, and to have a backup insulin supply as any other child with insulin pumps. They need to be ready for failure of the device anytime. And it's the use of insulin, the automated insulin delivery devices was endorsed by ISPAD and ADA also, and it's to help in fasting safe. And it's both the consensus emphasize on individualized care and caregiver education. So in conclusion, fasting in children with type 1 diabetes is possible with careful planning, and smart insulin pumps and CGM significantly improve safety and glycemic control. And after all, collaboration with diabetes care team is essential for success, safe fasting. Thank you very much.
Thank you, Dr. Azza, for this comprehensive talk about Ramadan fasting. So now we are open for the questions. If you have any question, kindly write it down in the Q&A section. Well, there are no any questions I can see. Let me ask you, Dr. Azza. So if you said the pre-assessment test has to be 2 to 3 months before Ramadan, right? So if you have patients who you're seeing and they cannot come to you, is there a way to make these information reach them?
So of course, now after the COVID pandemic, we learn a lot. We learned that using telemedicine can help in this. So if you have a problem with reaching your patient, it's always possible to reach them with telemedicine or virtually, and explain all of this. Even dietitian, diabetes educator can have a session, a group session, or a session, individualized session with these kids to explain and prepare them for this.
Okay. So we have a question here by Ziad. Previous Ramadan in Oman, you are face any complication for children fasting?
In my institute, we did not face any problem. We did not have any like a patient who seek hospital admission because he is fasting actually. But there's patient interrupted their fasting because of hypoglycemia. And this is common actually.
Yeah, so the common complication is the acute
Yeah.
glycemia. Even us, we didn't see DKAs, but mainly hypoglycemia. So we have another question. What is the possible reason in increasing blood sugar after exercise?
So it's physiology. So if the patient is exercising, it's he's stressing. So stress hormone can go up and that cause hyperglycemia. The children with after exercise, they can get hypoglycemia or hyperglycemia according to their body response, but mainly hypoglycemia. But there is patient who get hyperglycemia after exercise, especially if they start their exercise with hyperglycemia. That's why we advise children to check their blood sugar before exercise. And if it is low, they should take something and make sure that their blood sugar is normal. If their blood sugar is high, they should not exercise. They should do measure to reduce their blood sugar.
Okay. So another question, what is the at what age you can allow children to fast? Some families, they can allow fast their children by age of 9 years or 10 years. So what is your answer?
It's not advised for 7 to 8 to advise. It's safe to allow them to fast by 12, but this from 8 to 12, you can individualize and assess the child, as we said, how's his blood sugar control, does he have hypoglycemia in awareness, any risk of any recent DKA, as any other child. But we advise the children to start fasting by 12 and above, actually, not before that. But many, like last week, I have a child who was 9 years and he was insisting he want to fast. So this child, whatever you do, he want to fast. So we have to give him guide how to fast.
And I think you answered Dr. Irfan's question. If a child who is not controlled and insisting to fast, how to counsel those 10-year or below who wants to fast, how you counsel them not to fast?
We explain to them that they are not actually mandated to fast. يعني في رخصة, you are not mandated, but the main concern of these children is the stigma at school, actually. When all kids in their age are fasting, and they will ask him, are you fasting? Show me, open your mouth. So this is stressful for the kids. So we tell them, you can fast half day till you reach home, and then you break. But if they insist, just with the stress on frequent monitoring of blood sugar. Now, alhamdulillah, most of our kids are on sensors, and they can see, and they should act on the arrows and trends on the sensors. If they saw it's trending toward hypoglycemia, they should break the fast.
Yeah, sometimes even at home, this challenge happens. So
they compare with the family.
There is another question saying, one of my patients I advised to break fast is if the blood sugar more than 300. She asked why not only taking insulin dose and continue fasting. What is your opinion? Interesting.
I think that because they will go into dehydration. So she can try giving an insulin dose and see the response. But these kids, if they have hyperglycemia, they have polyuria, they go into dehydration, and that's risky for DKA. So they should know that DKA is a serious complication, and they should not risk that. They should not take that risk. But
Yes.
she can try to give a dose and see the response, but we usually advise them to break fast and drink water and take insulin.
Because 300 is very high, actually. If it is
Yeah.
mild hyperglycemia, then fine, but
Yeah.
300 is very high. Okay, after Ramadan, do you have follow-up all those children fasting or regarding to their appointment only? Or you have contact by other way? So you do follow up all your patients after Ramadan?
We follow as regular, so we don't give them special appointment after Ramadan, but we have like WhatsApp contact, and they can contact us on WhatsApp. We can also follow them their sensor blood sugar and see how they are doing. The diabetes educator do that, but we don't actually have we don't give them follow up immediately after Ramadan.
Yeah, so you answered even this question, which Ziad is asking if there is any phone application program to follow children fasting that can you assess the child medical condition, so by WhatsApp and
So we use WhatsApp, and we use the device cloud, which is like a LibreView for Freestyle Libre and Clarity for Dexcom, and see how they're doing with blood sugar monitoring.
So how can I make sure that the child is well hydrated? Any early signs or alert that I should look for?
You should look for like if the patient is at home, or if he come to the hospital, the doctor assess hydration status, like signs of dehydration. At home also you should like if he looks dry, if there's no tears, their mucous membranes are dry, it's like you check for signs of dehydration. We do advise them to drink a lot and to delay the sahur to before adhan, and drink water and eat before, so they will not go into hypoglycemia or dehydration. If the problem here is that most of the family, they don't have the sahur, they take it around 12, and then they sleep till Fajr. But we insist for children with the type 1 diabetes, they should delay the sahur till pre-dawn, adhan, so they have enough water and they have food before starting fast.
Yeah, actually there is a recommendation about the amount of water that you have to take all through. But the problem is when you keep all that water at suhoor and drink it at once. So,
And they should drink also through the breaking fast period, yes.
so there is a question here. Can you tell us about insulin pump? Is it the same regular one which was used before by medical practitioners, or it's a new one? Did you mean there is a device available for the parents? I'm not sure about this.
Insulin pumps are devices that used by children at home. It's not the insulin, the pump used in the hospital. So
Hospital.
there are devices available for the children at home. And it should be started in the hospital by a full team, diabetes care team, and all kids who are want to go into insulin pump, they have to learn carb counting. They need to learn a lot about how to button these devices, how to go to manage these devices.
Yeah, I think you showed a picture.
Yeah.
The last question is, do you have special initiatives for children before Ramadan? I think you mean the assessment of the pre-assessment that Dr. Azza answered, right? You talked about it.
We used to have group teaching for these kids, but recently we have any manpower issue, so we could not do it. But we do usually a pre-Ramadan group teaching. We bring all children at around, like those who are interested to fast, and they are educated by the dietitian, by the diabetes educator, and by the endocrinologist, and we explained to them all of this, what we took. But this year, unfortunately, we couldn't do it.
Yeah, there is a question. We brought it up. How much water should a 12-year-old kid drink in Ramadan?
I don't know exactly how many, maybe if you know, but they should drink through fasting. I'm not sure what, by liter, I'm not sure.
Yeah.
I cannot give you a
At least they can drink a glass or 2 glasses every time they eat. So, any more questions? I think we answered all the questions in the Q&A. Can wait a minute. Anyone has a question for Dr. Azza? Okay, a question came. Can you send for us this lecture, please? They want the lecture.
Okay. Can't send it to, well, I don't know how to send it actually.
It will be broadcasted in the YouTube channel
Okay.
of Ramadan Diabetes Association, or all lectures go there. So I think you can access that, Selma, and you will see this lecture, or you can contact the Oman Diabetic Association and see Instagram, through Instagram also. Anyone else want to ask? Yeah. Okay, there is someone who suggested maybe through our email, please. Well,
Because it will be there available in the Instagram, that will be live.
so Dr. Irfan is asking, reducing insulin by 35 to 50. It's wide range. How to decide?
So you individualize, I said, according to the pre-Ramadan blood sugar. You check, see how's your child doing, what is his blood sugar, like glycemic control, and what is the risk, any hypoglycemias before, any recent like hypoglycemia in awareness, and you tailor according to your patient requirement. Those kids who are uncontrolled, their the A1C is in the higher side, you should not reduce it much. But if you have a child whose hemoglobin A1C is been 5 and 6 pre-Ramadan, you should reduce it. And also you need to assess their eating habits during Ramadan also. Now, as I said, some families, they have 3 meals, some families, they have 2 meals, some families, they have more, lots of sugary and معجنات, this high in carb immediately after iftar. So this is an individualized assessment of a patient, and accordingly you decide how much you reduce.
So we have a question. If basal dose was high, how much should I reduce? So if the glargine is high, like
the same, the same answer. It's you assess your patient. So why he's on high, because maybe he's not controlled. It depends why you are giving him. Is it the age, or is he obese? Is he having insulin resistant and he's requiring high amount of insulin? What is his eating habits? So it depends on, it's by patient to patient. You cannot give you a number how much you reduce.
Yeah.
As we said from the beginning, as I said, that it's when you start your dose, you assess after, like in the beginning, first 3 days, how's the blood sugar, and accordingly you adjust also the dose. You'll not be able to give one dose and continue for the whole Ramadan. So, some kids, they get hypoglycemia, even if with your reduction you need further drop. Some kids, they have hyperglycemia, you need to reduce it further. So you give them the advice and you give them the contact and they communicate with you and you adjust accordingly. This recommendation is a start, and then according to the CGM or the blood sugar monitoring, you adjust the dose. It's not a fixed dose, just all through.
Did you notice better control of type 1 diabetes in adolescent age group?
Well, it depends. It's not all across. We have patients who are doing very well, their A1C are 5 and 6, and we have also patients who are not doing well. But what we did a small study with my colleague, Dr. Hussein, and we compared our adolescent before transfer to adult and after transfer to adult side. So we transfer our patient around 15 to the adult side, and we notice improvement when they go to the adult. Is it they are becoming older and their sense is better, they know that they need to control, or something else, we don't know, but with age they usually get better. This is what we knew from that study. But we have patients who are controlled, depends on the blood sugar control is lots of factors, including the family and the support and the access to technology and the family, the child willingness to go into carb count or not. It's lots of factors affecting the control of the type 1 diabetes. It's not just insulin.
True, even behavior, psychological.
Yeah.
Family support is very important.
Yeah,
also peer support is good. And the more the patient gets older, like young adults, they're more better controlled.
Yeah.
So our Q&A is empty now. Any other questions? Give a minute. I think we will end this meeting. Dr. Azza, thank you very much for your comprehensive, your interaction and your strategies about fasting Ramadan in type 1 diabetes children.
Okay, thank you very much also for again for having me today.
For attending this meeting. Thank you.
I hope they get benefit from this session and enjoy the session. Thank you very much again.